Monica, you go straight to Nicolas. Is that okay?
Sure. Thank you.
Okay.
So you can start when you're ready.
Okay. Hi, everybody. Good afternoon. Now we'll continue with lung function testing. First, Dr. Monica Gappa will be talking about multiple breath washout techniques. And then Dr. Nicolas Ragamey will continue with inflammatory markers. And we will have the questions at the end of both presentations, but I will gather them during the talk, so please feel free to post them on chat. Thank you.
Well, thank you very much, Refika, and good afternoon from me. The aims of my present talk are to give you an understanding of the concept of using inert gas washout techniques for assessing small airways disease, and I will talk about multiple breath washout this afternoon. And I hope you will, after this talk, know the most important parameters to describe ventilation inhomogeneity and have an idea about current research and clinical applications of these techniques. Now, why do we need other lung function tests than spirometry, which is readily available and used everywhere? And I think for pediatric respiratory medicine, this publication by Per Gustafsson in 2003, published in the European Respiratory Journal, shows you why we are looking at other tests than spirometry. Here you have lung function data, FEV1% predicted of children and adolescents ages between 5 and 20 years of age, healthy subjects, the open circles, and subjects with cystic fibrosis, the closed circles, and you see they are all overlapping, and there is not really a clear distinction between the group with CF disease and those who are healthy, at least not before adolescence and young adulthood. And at the same time, we know that unfortunately, quite a few of these patients have already marked structural abnormalities, like this child here with obvious bronchiectasis and pulmonary changes, and still has normal spirometry. Now, Per Gustafsson was the one who started using multiple breath washout again. I tell you more about the history later. And he did show that with multiple breath washout and the parameter lung clearance index, you are able to distinguish between healthy subjects and subjects with cystic fibrosis at a much younger age, when the children are clinically healthy. You see that the cystic fibrosis patients have a lung clearance index which is higher than that seen in healthy children. And that's the explanation is that spirometry is not a good test for small airways, and small airways is the area where CF lung disease mostly starts. And I have a picture here of a beach towel and a tennis court. And actually what the spirometric parameters measure are the central airways, and they are sort of equivalent to the beach towel. And what we need to look at are the small airways, and they have the compared size of a tennis court. And you see here, this is spirometry, and this is what we need to look at. So we miss a lot when we do just spirometry. What are the small airways? Now, this is a schematic figure of the human airway tree. The generation 0 is the trachea, and then it's divided into the right and left main bronchus, and you know that each bronchus divides again, and that goes on for 23 generations. Only the generations 0 to 8 are reflected by spirometry, and then you have the remaining small airways up to generation 23, which are the small airways. And the area of the small airways is much bigger than the area of the large airways. It's like a trumpet, and that explains this comparison between the towel and the tennis court. Small airways have a lumen less than 2 millimeters, at least in adults. It's generation 8 to 23, I said that already, and they account for 95% of the total lung volume. Because the volume is so large, they contribute very little to total airway resistance, and therefore the changes in the small airways can really be masked using conventional lung function techniques. That is also why they are called the silent lung zone, and in the beginning of modern respiratory physiology, this has been assessed using bronchial catheters, so a rather invasive method, and then using gas washout techniques like multiple breath washout. Now, one other term you need to know, there are conducting airways and there are the intra-acinar airways, which we have for the gas exchange. Conducting airways down to generation 17 and then the last 6 generations for gas exchange. Okay, some more background. The efficiency of gas mixing within these small airways can be assessed using gas washout techniques, and the efficiency is described by parameters of ventilation homogeneity. Even in a very healthy person, there is some inhomogeneity. It's not a, there's some inhomogeneity because the branching of the airways is not absolutely symmetrical. But this ventilation inhomogeneity will increase in disease. And the most commonly used technique in pediatric respiratory medicine is multiple breath washout. Multiple breath washout is performed during tidal breathing, and therefore it is applicable to theoretically to all age groups. It is performed at resting lung volume, which is equivalent to functional residual capacity. So you just ask the subject to continue breathing normally. And you use either an inert gas of a different molecular weight compared to the room air, and that can be sulfohexafluoride, SF6, which is very heavy, or helium, which is very light. If you use an inert gas like SF6 or helium, you need to perform a wash-in into the lungs first and then a wash-out. And the alternative is a nitrogen washout. If you substitute the room air by oxygen, then you can wash out all the nitrogen which is in the lungs. What you have to know, if it takes very long, endogenous nitrogen from the mucosa may contribute to your measurement. And here you've got a trace, time and volume. Tidal volume here, lots of breathing in and breathing out. And here the nitrogen starting at 79% room air concentration of nitrogen, and then wash out with oxygen until the nitrogen is below 2% at the end of such a washout. And here you see this in a little bit more detail. You've seen these traces before: tidal volume, concentration of nitrogen. You do tidal breathing, then from room air you switch the subject into oxygen, and all the nitrogen that comes out of the system can be measured and will decrease breath by breath by breath until the concentration, and that's just an agreement, is down to 1/40 of the initial concentration. During this washout, you will measure tidal volumes, and all the volume that has been here during this tidal breathing is cumulated or added up to cumulative expired volume. And the FRC, the functional residual capacity, Nicolas has been talking about that before, is the volume of expired nitrogen until the washout is complete. And then you will assess the time or the volume that it takes until the nitrogen concentration is lowered to 1/40 of the initial concentration, and divide, or the cumulative expired volume divided by the FRC then gives you a measure of ventilation inhomogeneity, the lung clearance index. And what it actually is, the number of lung volume turnovers, the number of times a subject needs to breathe his FRC until nitrogen is washed out. For a normal subject, it will take about 7 times the lung volume until it's completely washed out. And if there is disease, it will take longer. So the number of lung volume turnovers, the number of times the FRC has been tidally breathed is similar to the lung clearance index. In practice, you have a child sitting upright at the system you are using, starting tidal breathing, and when the tidal wearing a nose clip. Sometimes it can be useful to have a quiet video to distract the child from this sometimes boring procedure. And when you have established tidal breathing, quiet tidal breathing, then the switch into oxygen or into the inert gas is done, and then you start the washout until an equilibrium is reached, and then the concentration is below 2%. Then you can stop and the calculation is performed. You repeat this for 2 times, and a quality criterion is if you have the FRC within 10%, you know it's repeatable. I said already in a normal person, the LCI is around 7, which means turnover of lung volume 7 times during the for the washout. But it depends a little bit on equipment and on the gas used. If you have older subjects, LCI will increase slightly, but not very much. During the period of childhood, school age, adolescence, there is no change really in, or it's there are stable reference values. And the variability is also very low, like the volumes in spirometry, around 5% in healthy subjects. And a clinically relevant change is probably 1, ±1 for the lung clearance index. It is very important to have a very regular tidal breathing, and the most common pitfall during this measurement is that you have a leak, because the subject will not close the lips tightly around the mouthpiece, and if you have a leak, then for the nitrogen washout, room air is drawn in, and this will prolong the washout and lead to falsely high FRC and falsely high lung clearance index. Here you see the nitrogen curve, and there's a sudden increase in nitrogen here again and again and again. And this is an obvious leak where additional nitrogen is drawn in from room air. It can be less obvious. There's a very nice recent publication from Switzerland. But here, if you look very closely, you see there is an increase in nitrogen concentration towards the end of the washout, and this will change your results, and you have to be really careful to watch for that. The most common, this is where leaks can occur. This is a schematic setup where you have your mouthpiece, ideally sometimes a mask, attached to the patient. Then you have your measurement device and your gas supply. And the most common occurrence of a leak is here at the mouthpiece, or the mask, a so-called pre-capillary leak. And this is something you have to watch very carefully. I told you that MBW is not a new technique, but it's rather old, and there have been publications in pediatric respiratory medicine already in the 1980s, also from Switzerland. Richard Kramer and co-workers, University of Bern, did do some very very good studies in patients with cystic fibrosis almost 30 years ago. And what you see here is an example of a nitrogen washout in a patient with cystic fibrosis and in a healthy child. You see that the washout is much longer in a cystic fibrosis patient compared to the straight washout in a healthy subject. And he did calculate the lung clearance index and also looked at some other parameters. But my question here is, which of the parameters indicated on this figure here is equivalent or represents the lung clearance index? Is it M1 over M0? Is it M2 over M0? Is it the FRC, functional residual capacity, or is it CEV divided by FRC? And you can vote now. Can you show the results, Amy? Okay, so you have all understood that CEV, cumulative expired volume divided by FRC, that is equivalent to lung clearance index. But he also, that's correct, yes, he looked at some other parameters, the moment ratios, which describe the degree of skewness of the washout curve at different parts. So the beginning is M1 over M0 and the end of the washout is M2 over M0. And he looked at slope analysis, which is really a breath by breath image of ventilation in the very small airways. Here you have one back, yes, a schematic or an example of a slope in a healthy subject where you have a very straight slope, very, very little inhomogeneity, and here you've got a very steep slope in a cystic fibrosis patients where you have marked heterogeneity and a slower washout of the resident gases. And actually slope of a single breath is divided in several phases. It's the dead space ventilation, a transitional phase, and what we are interested in is the alveolar gas phase 3, where you usually see an upward slope because the gas is coming from multiple compartments of the peripheral airways. Here you see an example, this is illustrated again here. Here you have a phase 3 slope of the very first breath of a washout, and here you've got a phase 3 slope towards the end during the washout at the 10th breath, and you see that the initial phase 3 slope is less steep, or there is an increasing slope as washout continues because you reach more and more peripheral airways and there is more and more ventilation inhomogeneity. And if you plot these breath by breath during the washout, here you have the lung turnovers. So imagine there's tidal breathing in, out, in, out, in, out, in, out, 7 times for a healthy lung to completely empty the lungs. Then you will see a low slope 3 here at the very beginning, and then a continuing increase towards the end. And this phase 3 slope analysis helps you to I will also describe small airways changes, And it has been shown that if you look at the slope of the first breath versus the steepness of the slope of the remaining breath, this will differentiate between convection dependent inhomogeneity in the larger airways and the convection diffusion dependent changes in the smaller airways. Now, I told you there are reference data available for the lung clearance index, but they are equipment dependent, and the most recently published data actually are from this year, from a multinational working group who have established reference data with the aim to have a basis for clinical trials in cystic fibrosis. Here the lung clearance index, but also for FRC and moment ratios. And indeed, the most common clinical application of multiple breath washout is in patients with cystic fibrosis. There is a huge number of publications over the last 15 years, and this is just one example from the Cystic Fibrosis Working Group in London, who have done measurements of spirometry here, FEV1, bodyplethysmography, RV over TLC as an index for hyperinflation, and then the lung clearance index measured using multiple breath washout. And what I've told you for spirometry, that there is an overlap between healthy subjects and cystic fibrosis subjects, is not quite, but also true for parameters of using bodyplethysmography. And there is this very good distinction between healthy controls and cystic fibrosis using the lung clearance index. It has also been shown in several studies that the lung clearance index correlates with structural changes that are seen on CT. So and it has been shown that the LCI gives you an is a prognostic value. Here you see a lung clearance index measured during preschool years, and those children who have an elevated LCI already when they are 4 and 5 years old, they are much more likely to have an increased LCI, so an indication of small airways disease when they are at school age, whereas those who have a normal LCI during preschool years have a much higher chance to remain normal here, which certainly gives a much better prognosis over long term. Besides cystic fibrosis, there have been mostly research applications. There are a number of studies in asthma and PCD, post-lung transplantation for detection of bronchiolitis obliterans. In adult patients, there have been studies looking at the effect of tobacco smoke exposure, and there is an increasing interest to look at ventilation inhomogeneity as early markers of COPD. And of these sort of topics, the primary ciliary dyskinesia patients are most similar to cystic fibrosis, and there is some value for clinical application of multiple breath washout in this group of patients. There are standards for inert gas washout measurements, both single and multiple breath washout tests. And there's also a very highly recommended document for preschool multiple breath washout testing, which is listed in your literature list. And here I come to the end of my presentation, and just to summarize, spirometry is not sensitive to changes in the small airways where many diseases start, and multiple breath washout is a method that can be used throughout the pediatric age groups and is much better to detect small airways disease and ventilation inhomogeneity. It is a tidal breathing test for all ages, requires regular tidal breathing, and avoidance of leaks during the sometimes boring measurement is essential. You can do inert gas washout using pure oxygen for nitrogen washout, or using separate gas like SF6 or less commonly helium. And the lung clearance index is the parameter which you have remember, it's the most commonly reported. There is commercial equipment available, reference data for some of this commercial equipment, and the clinical and research application is mainly cystic fibrosis, but there's a lot happening and it's worth watching out. Thank you.
I'm sorry, Nicolas, we can't hear you. You need to unmute.
Like this, okay?
Perfect, thank you.
So I go on with the last presentation about lung function, about inflammatory markers, and I will mainly talk about FeNO measurements, as you will see. So okay, do you hear me? I hope so. So I hope that after this presentation, you will especially remember the differences between FeNO measurements and nasal nitric oxide measurements, that you know what are the applications of FeNO measurements. I would just very briefly tell something about exhaled breath condensate, and also sputum eosinophils, because in clinical practice of everyday practice, this is not something that you will probably use. So we can measure airway inflammation at different compartments, and non-invasively, the easy thing is to analyze the air that you exhale. And what we will mostly measure there is the fraction of exhaled nitric oxide. Volatile organic compounds, or also substances that you will find in the fluid that you condensate from expiratory breath, or sputum, will be less used for inflammation, but you can also analyze them. I will not talk here about invasive measurements like bronchial lavage or endobronchial biopsies. So now I will read the question to give you the time of this first question. So which of the following statements about exhaled nitric oxide levels in children is true? Nasal nitric oxide concentrations are less than those in the lower airways. FeNO is dependent on expiratory flow. Spirometry should be performed before FeNO measurements. Ambient air should be inhaled before FeNO measurements, or the upper limit of normal is 50 ppb. So I think I might go to the slide. Is that okay, Amy?
Yeah, so we'll just give a few more seconds for voting.
Okay.
They're coming in very quickly.
So you tell me when I can switch.
Results.
Okay. So thank you very much for these answers. So I think most of the people have answered correctly, so that FeNO is dependent on the expiratory flow. The nasal nitric oxide concentration in the nose are much higher than in the lower airways for the first question. The third answer is the spirometry should not be performed before FeNO, because you will have false values. Not ambient air, but FeNO-free, NO-free air should be inhaled, and the upper limit of normal is somewhere in children between 15 and 25, as I will show you. So nitric oxide is a substance, is a gas that is produced by the metabolization of L-arginine, which is an amino acid in citrulline. And this occurs everywhere in the body, but especially it can occur in the lung epithelial cells under the influence of inflammation, pro-inflammatory cytokines. And these inducible NOs, nitric oxide synthetases, will produce NO that will be exhaled in the air. And FeNO has been shown to be a very good marker of eosinophilic airway inflammation, not neutrophilic, but eosinophilic inflammation. Therefore, is it increased in allergic asthma, because it's an inflammation eosinophilic of the lower airways in eosinophilic asthma, allergic asthma. And if you give inhaled steroids, it has been very early been shown that the levels decrease after inhalation. And this test actually has been published or analyzed the first times more than 20 years ago. So how can we measure this fraction of exhaled nitric oxide in the air? So these are very, very small concentrations, or these are parts per billions. So if you want to give NO, this is also a therapeutic gas, in a therapeutic manner to do a vasodilatation of your bronchial vessels, you will give part per million. So you will give 1,000 times higher levels than what is normally expired. So very, very small concentrations, and to measure these very small concentrations, you need very, very sensitive analyzers, and the usually used analyzers will measure the light generated by a chemical reaction of nitric oxide with ozone. But these instruments are quite bulky, they need a very good maintenance, and they are also quite expensive. So a lot of companies have fabricated smaller portable devices which work differently with electrochemical sensors. They are also cheaper, but they will be a little bit less sensitive than the larger machines. FeNO expression in the exhaled air increases with age. So small children have usually values less than 15 ppb, and adolescents less than 25 ppbs. And really a cutoff is depending on the age, but I would say many pulmonologists use just a cutoff of 20 for all ages and say that's about the level where it's elevated. There are important recommendations how you should perform the measurement of FeNO, of exhaled nitric oxide. So the recommended measurement technique is the so-called single breath online method, where you inhale first NO-free air. So there has to be a filter that filters the NO out of the air so that no particle of NO will be in the air you inspire. And then you exhale your NO against a small resistance. Why this? Because this will shut your velum, your soft velum, and then only the air that comes from the lower airways will go out in this analyzer and be analyzed. If you don't do this, or if you do an inspiratory maneuver at the same time through your nose, you will contaminate the lower airways with air of the upper airways, and air of the upper airways contains 10 to 100 times more nitric oxide than in the lower airways. So this is very important. It has to be constant flow. If you do a too fast expiration, then you will have like a dilution of your FeNO that's produced in the air, and then you have too low values. If you do a too slow expiration, then your values will be falsely too high. So to see that you really expire the constant flow of 50 milliliters per seconds, you usually have devices which give you a biofeedback, like for children, a balloon, that when you blow too fast, the balloon is too high up in the sky, and if you're too slow, the balloon is too low. And so this will allow you to really expire at a constant level of 50 milliliters per second. There are alternative methods to measure FeNO in younger children, because this is a difficult maneuver to do during several seconds at a constant flow. And for smaller preschool children, they have some less standardized method where you can also measure FeNO, for instance, by the so-called multiple breath online methods. Here you just breathe normally. Also, of course, you inspire NO-free air, but you breathe normally, and you will measure the concentration, of course, vary in the expired air during 2 to 3 minutes. And then you have kind of a mean value that you can use to say if there's too high or too low FeNO in your exhaled air. This is important that such a method is not corrected for flow, so of course gives you less accurate values. You can also use the tidal breathing offline method, which is similarly a method that can be done by small children, where basically what you do is just you inflate a mylar bag, and then this bag will be offline you will test the concentration of the nitric oxide in the bag, of the air in the bag after the exhalation. And also this technique is not corrected for flow. So besides the age that we've talked about, which will increase your FeNO as age increases in your air, there are other factors that you need to consider that can modify your FeNO measurements. They are all listed here in this publication, but I think the most important are depicted here. So the ambient air, of course, is important, because sometimes in the ambient air, especially if you live in a large city, you will have values of 100, 200 ppbs, and you want to measure a value of 10 to 20 ppb in your air. So a contamination of the ambient air will give you falsely high results. As I said, the contamination of the nasal NO is a bad thing. If you do prior spirometry, then you will kind of empty completely your airways, and you might have false low values if you perform the FeNO measurement after the spirometry. And as I said, the flow of, if you expire too quickly or too slow, will modify your FeNO levels. And also if you hold the breath before doing the maneuver, then you will accumulate the FeNO in your lungs and then have too high values when you expire it. So we go to the second question: which of the following statements is true? Is a symptomatic child on ICS with FeNO of 45 ppbs, adherence to treatment should be considered? Yes or no? Or yes. Is this true? Or two, FeNO measurements have been shown to be useful in the clinical management of patients with chronic bacterial bronchitis. Or beta-2 agonists should not be used before sputum induction with hypertonic saline in asthmatic children. Titration of ICS on sputum eosinophils reduces exacerbation rates in children with severe asthma. Or FeNO less than 200 ppb strongly suggests primary ciliary dyskinesia. So please vote. And Amy, tell me when I can go to the next slide, please.
So we're sharing now.
Okay. So most of the people have voted for the number 1, and that's absolutely correct. The numbers 2, the FeNO measurements have been shown to be useful in the clinical management of patients with chronic bacterial bronchitis. No, that's not correct, because it's a neutrophilic inflammation. Beta-2 agonists, they should be used before sputum induction with hypertonic saline, because hypertonic saline can produce bronchoconstriction. Titration of ICS and sputum eosinophils unfortunately has not been shown to reduce exacerbation rates in children with severe asthma. And FeNO, it's nasal NO less than 200 ppb that strongly suggests primary ciliary dyskinesia. So the measurements of FeNO can be used in several ways, especially in the management of allergic asthma. But it's not just the measurement of FeNO alone that will tell you if you have a good control of your asthma, or if you should change treatment or whatever. So it's really just one of the tools, like this Swiss Life tool, that will help you like a puzzle peep to adjust your treatment or to make a diagnosis. It can help. As an example, if we have here 2 children with exactly the same history, a 15-year-old girl or a 7-year-old boy, both have recurrent dyspnea episodes during exercise. They both have, the day you examine them, a normal spirometry. Well, if you measure FeNO and the girl has just a normal FeNO, maybe you will think rather, oh, maybe this girl might have vocal cord dysfunction or another problem, or just not be trained or so. Maybe she has asthma. Yes, we cannot say, but you will rather think about this. And on the other hand, with the boy that has a FeNO of 45 ppb, so hints for an allergic airway inflammation, you will rather think this child might have asthma. In this paper of which is a nice review about the use of FeNO, you can see how you can use the FeNO in diagnosis or treatment. As diagnosis, that's just what we talked about. For the monitoring, for instance, if you have a child that has a known asthma, still has symptoms, and then you have a low NO, well, then you will have to think, well, could he have something else other than asthma? Is it really allergic asthma? And probably if you give him just more steroids, he will not be better. On the other hand, if he still has symptoms and has a very high FeNO level, then you will have to think, well, is there still an allergic exposure there? For instance, are there house dust mite sensitivity allergies that still have not been addressed with the preventive measures correctly? Or is really the child taking the treatment, or is it doing the inhalation correctly? Very, very rarely you will have resistance to steroids. And of course, if you have high FeNO measurements, it's been shown that there is a risk of subsequent exacerbation of your asthma. An application that is not so often used in clinical practice, but we, for instance, do this routinely in children that preschoolers that have recurrent episodes of wheeze. The question of the parents will often be, well, does my child have already asthma? Will the child develop asthma? Then maybe the measurement of FeNO can help predict asthma in these children. This has been nicely illustrated by the study of Florian Singer a few years ago in children that have not, these were preschool children with cough or wheeze. In these children that have not developed later asthma, FeNO levels were normal, and those who have developed asthma, FeNO levels were higher. Of course, it's not discriminative. There is a huge overlap between the two groups, but it can help. The same with non-selected children here. So importantly is not to confuse FeNO with nasal NO measurements. These are very different compartments that you analyze. The nasal NO, this comes from your sinuses here. It's measured when you breathe slowly through a straw, for instance, also to close your velum. And here you will just have a thing put in your nose that aspirates the air in your nose. And here, if your FeNO levels or nasal levels are very low, it is a good screening test, or is it quite a sensitive test for PCD or also for cystic fibrosis. The reason why the nasal NO in these patients is very low is not completely known. There are different hypotheses that are shown here. Either the NO is degraded, or because there's a problem between cilia and NO production, there's a reduced biosynthesis, or maybe also it's a problem of the NO that has been trapped in the sinuses that are obstructed. So I'll be very short in the few last slides about exhaled breath markers. If you're interested in this, there's a nice review paper on these markers that is shown here that has been published 3 years ago in the ERJ. So basically you can measure inflammatory markers in the breath, or also in the condensate of your breath, where you have just the fluid of your breath that is being cooled and has been condensated, and where you can analyze your particles. For instance, in the exhaled breath, we have talked about a FeNO that you can measure. You can also measure temperature or other compounds, volatile organic compounds, and you will measure these compounds with different complicated, sophisticated measurement techniques like chromatography. You have systems which give you qualitative analysis and profiles of different compounds that you find in the air, like the electronic nose, where you might have heard of this, where you get like patterns of different molecules that are exhaled, and where you can, with this pattern, group patients according maybe to disease or according to pathogens they have. This has not been really put forward in clinics of every day, but is still in research applications. For instance, here a research application where a group has shown that using volatile organic compounds that were analyzed in breath helped to better discriminate children, preschoolers that will have asthma later in school age compared to those who will not have asthma. This here curve is just if you use the asthma predictive index. The curves here are if you add also some profiles of gene profiles. And finally, the best discrimination we'll have will be if you also add volatile organic compounds. So the last thing is the induced sputum in children. So for inflammatory, this has unfortunately not really a big role. It's the technique where you induce sputum by inhaling first hypertonic saline, which will make you cough. So that you don't get a bronchoconstriction, you first do a pre-treatment with salbutamol. And then in the cells, you can analyze either soluble mediators or the cells. It's time consuming and unfortunately it has not been yet shown to really be useful in treatment management. But of course, it's a technique that is very important for microbiological analysis, where you will use this to look for bugs, for instance, in cystic fibrosis, in protracted bacterial bronchitis, in PCD, or in tuberculosis. So this is the summary of my talk. FeNO is helpful in asthma management. In diagnosis for PCD, you will use nasal NO, and the other tests, breath condensate, induced sputum, are still more for research. Thank you very much for listening.
Thank you, Nicolas and Monica. So we have a few questions. I'll start with Nicolas's questions. There are two. And the first one is asking about patients with allergic seasonal rhinoconjunctivitis. How high can FeNO be due to allergic rhinoconjunctivitis? And the participant is asking about particular situations when patient has high FeNO, like 80, but normal spirometry, but has rhinoconjunctivitis. Can this be blamed on the rhinitis only? Okay, you're muted, Nicolas.
Let's put myself here. Do you hear me?
Uh-huh.
Well, we have the concept of united airways. So, you know, allergic inflammation starts here, might start here at the nose and end at the very end of your bronchial tree. And theoretically, the FeNO measurements really just comes for your lower airways. Theoretically, if you do a complete closure of the velum, you would say, no, if you have a patient that has just allergic rhinoconjunctivitis, that has no allergic inflammation in the lower airways, the FeNO should be absolutely normal. But this is more a theoretical consideration, because your allergic inflammation in asthma is not just in the bronchi and in the allergic conjunctivitis just here, but it's more diffuse in the airways. So there are atopic patients without a proven asthma that have also higher levels of FeNO.
Thank you. And this question, next question, was partially answered by one of our participants and the case presenters. And it asks whether FeNO can replace spirometry in asthma diagnosis.
No, clearly not. I've shown it, it's part of a puzzle. It's one of the tools you have helping in putting a diagnosis of asthma, but you will never give an asthma just with a FeNO measurement, the asthma diagnosis.
Thanks, Nicolas. And the next questions are for Monica Gappa. And so the first one says, asks about if the LCI has been compared to force oscillometry R5 and R20 values.
To be honest, I think there probably is somebody who has done such a comparison, but I'm not aware of any publication.
Okay, and also I think you did highlight this after the question was posted, but the question asked if you could highlight on the slope conducting airways and slope of SNR values and disease conditions other than CF they can be applied. And this question was posted before the slides that you showed, but maybe if you could summarize.
Yeah, there are some questions or some research questions which have been addressed with this specific SOAP3 analysis and convection dependent, diffusion convection dependent inhomogeneity. And this is particularly the post-transplant assessment, development of bronchiolitis obliterans, and the effect of tobacco smoke exposure. So more adult topics where this has been done, but there is also publications in cystic fibrosis. So yeah, it's a very specific research question and it's not so much a clinical application.
Thank you. And the next question is asking whether there's any data on LCI being used to define cystic fibrosis exacerbations.
Yes, there are data, but this is not the best, I mean, this is not the strength of the lung clearance index, because for exacerbation, it's difficult to define what is an exacerbation anyway. The lung clearance index may give an additional idea. Actually, I've got some examples in the case presentations for tomorrow where the lung clearance index sort of is first because before clinical signs of an exacerbation or deterioration occur. But it's not the only parameter that will define an exacerbation.
Okay, thanks. And the same participant also is asking whether you can do multiple breath washout testing using the same device which measures lung volumes using FRC.
Yes, FRC is part of the multiple breath washout. If you do multiple breath washout, you will always end up with an FRC. It's a different FRC measure, lung volume measure, compared to plethysmography, which Nicolas has been talking about in detail. It's not the entire thoracic gas volume, but it's only the volume communicating with the airways, but it will give you an FRC. And if you do an additional spirometric maneuver and have repeatable measurements, you will be able to calculate you will be able to calculate the total lung capacity the same way you can using plethysmography. Okay,
that was a big thank you, Monica, for you. That participant was able to understand S111 the first time. And I think I'm just looking if there's anything else.
Am I just saying
some questions for you, Nicolas? Okay, do you want to go ahead?
No, I just think there's been one very important comment of someone writing that we need to ask for smoking because it interferes. This is on the table. Yes, you have seen that on the table that I copied on one of the slides. I've not mentioned it as one of the most important things in children, but it's of course very important, especially in adults, and yes, also in adolescents, of course, to ask for smoking. What I actually don't know really, and it would be an interesting question, I don't know if other people know how passive smoking has been shown to interfere with FeNO values. I just don't know, but maybe someone knows about it. And another question that has been answered already is if there are data on inflammation assessed with the ENOs in preschool children. Certainly not yet for clinical practice, but there are several studies running, and one of the participants also described one of the studies on ENOs and volatile organic compounds in preschool children that they will assess. And I guess it's someone from the Netherlands, because ENOs in the Netherlands is very advanced in the development. Yes.
And there was another question for Monica, multiple breath washout. How does it differentiate restrictive lung disease from obstructive lung disease?
Well, it will not be a single multiple breath washout measurement. I think you need other tests like spirometry and ideally plethysmography to confirm if you've got low lung, or if you suspect low lung volumes and restrictive lung disease. But if you have low lung volumes and have a normal LCI, then is consistent with a pure restrictive pathophysiology, and if you have increased LCI, there will also be some obstructive changes in the small airways.
Thank you. And what will be the FeNO in CF with asthma? Very challenging question.
Well, yeah, it's a good question. I like the question. And I like also the comment of Gordon Slabbers, who writes, Maria Pinionburg knows probably about passive smoking FeNO. Yeah, she's not here commenting, but I'll ask her later if she, and we can give you the answer there. Yes, that's a good question about FeNO in CF with asthma. So basically, children with CF have lower levels of FeNO, but there are children with CF and asthma who have higher FeNO levels. There are few studies that have studied this, and in my clinical practice also, I can say it can be useful to monitor if you have a child with cystic fibrosis and asthma. Then it's worth doing FeNO measurements, because if they are elevated, then you have an indication the child has eosinophilic inflammation, and that would be a child that I would give additionally to the normal treatment of CF, also an asthma treatment, especially if it has clear bronchial reversibility, but this is of course already with CF something that you have, but also in the clinical practice, then you see that these children also react to this. So it's also one piece of the puzzle that can be used. On the other hand, if FeNO is normal in a CF child, well, it doesn't say that he does not have allergic inflammation.
Thank you. And there's another question, does CO monitoring helpful in asthma? So maybe, I don't know what CO, do you guys know?
CO monitor, well, CO monitor, I don't know what. I think if it's the question about FeNO measurement monitoring, yes, I talked about this, and it's certainly a help. It's not you will not monitor your asthma only with FeNO, but it's helpful. And CO monitoring, this is probably a narrow.
Carbon monoxide. So the it's the carbon monoxide monitoring.
Oh, yeah. Okay. I don't know how you would monitor your CO asthma with CO. Certainly you can measure in blood gas analysis CO contents to see if people are smoking, and this will be an additional marker, but not for asthma, not that I know.
Okay. I think there are only two more comments left. So one of them was a comment. There was a FeNO level of 225. And patient was symptomatic, but had normal spirometry. I don't know if you wanna, there was no question posted, but do you wanna comment on that?
Well, it does not exclude that the patient has the normal spirometry does not exclude that the patient has asthma. It can be that the patient just had a recent exposure to any allergen, and that he, in 3 days, he will have an obstruction that you document in his lung function. It can be that if you stimulate him with methacholine, he will have a strong provocation. It can be also that it's he will not have an asthma. So as we say, FeNO alone does not tell you it's asthma, yes or no. It does not tell you it's controlled or not. It is one of the pieces of the puzzle that help you to manage asthma.
Okay. And a clinical question, how long we can give nasal steroid in allergic rhinitis?
Long. At least if you start to do a trial on topical nasal corticosteroids in allergic rhinitis, you can probably do it for 6 to 8 weeks. And the recommendation is to then taper it down and use it as needed. But it depends on the allergen, and like inhaled corticosteroids, you can also use it for very long.
Okay. And I think we have a time for 2 more questions. Does the level of FeNO give you an indication of severity of asthma?
No.
No. It's it gives you an indication of the severity of the allergic inflammation, but this is not equivalent to the severity of the asthma. I think we can say like this.
And there was a comment from the participant who asked about the carbon monoxide, and she said there are now some FeNO devices that can also measure carbon dioxide, and mostly used in smokers. So maybe that's something that adults use more. And the last question is, FeNO is it a parameter for asthma or only for allergic asthma?
It's related to allergic inflammation, eosinophilic inflammation, and in neutrophilic asthma, you will not have elevated FeNO.
Okay, I think I have completed all the questions and comments, and I really would like to thank you both and the participants for this interactive great session.